Started. So yeah, if you are new here, so we have Dr. Kirsten Thompson. So she is a board certified psychiatrist, and I'm very excited to have her because she has some very unique interests too, especially with women's mental health. She has a very unique practice that she runs as well in the LA area. So yeah, thank you for being here.
Yeah, I'm so excited. This is fun. Thanks for having me on too. I'm excited to get to know you more too, personally, but maybe we'll do some of that, another time too.
Yeah, of course. So the way I wanted to start was that I really wanted to ask you about your journey. So I know you alluded to it a little bit briefly with the surgery transition, but just walk us through what was your journey like starting off, let's say, from college up until now?
Yeah, so in college, I was an engineer. I always like loved math and science, and I started my career on Wall Street. So I worked at JP Morgan right after college. But I'd always loved medicine and people. And my first day of work on Wall Street was September 11th of 2001. And I was like 2 blocks away from the building. So when the Twin Towers collapsed, I had to run and I thought I was going to die. And I was 21 at the time, so I'm old now. But I looked to my right and left as I was running and saw all these older people in finance like clutching their briefcase. And I had this sort of sensible moment of like, fast forward, Kirsten, if you were in their shoes and like 55 and you just worked on Wall Street your whole life, would you be happy with like how you spent your lifetime? And I realized the answer for me was like, no. So I was supporting myself. So I kept working in finance during the day and then started volunteering at night with people in hospitals around New York, just cleaning bedpans, things like that, and realized I really loved caring for people, like a caring role. And so I quit Wall Street, went back to school to take pre-med classes at Columbia, and I worked in psychiatry there. I loved it. And then went back to medical school when I was old at 26. Old, and it's air quotes, because at the time I was like, nobody can switch careers at 26. It's too late.
Yeah.
And now I'm so glad I did that, obviously. So then I went to medical school in New York, and then I came out here to LA to be a surgeon. I got my first choice at USC for general surgery. So I did 2 years of general surgery training, which was really incredible. But then the more surgery I did, I was realizing I was much more interested in people's emotional plight and, what got them to be in a gang. I was treating the gunshot wound or the stab wound, but it was more interesting to me, like, how could I help them emotionally? Why do they have lack of community? Why are they going to a gang? Or all these other myriad of questions. And the kind of internal experience of humans, as hard as it is, was way more interesting to me than kind of fixing anatomy and that sort of thing. So quit surgery after 2 years, although I'm really glad that I did it because I think I learned a lot about myself and humans. And then I became a psychiatrist. And so now I've been a psychiatrist for, including training, about 15 years. And I love it.
Yeah, that's crazy how that develops then. Like it's a complete 180. And you would think that people wouldn't want to do that. But I've met some people who have made that transition, or like if there were psych surgery one side to psych on one another side. So I was curious as to when you were making that transition, did you have doubts? Did you have fears? You already invested so much of your identity into being a surgeon, I'm sure.
I mean, totally. Those are great questions. So I think it's like a lot of things in life where you only know what you know. And so, I sort of thought medicine's so hard. You get this one residency spot in surgery, which was like a very coveted, incredibly competitive slot that I got. And I thought, I can't not do this, even if I'm a good surgeon, right? My sort of program leader was like, why are you quitting? By the way, this is a really coveted spot and you're a really good surgeon, which made it sort of that much harder for someone who, feels validated by external validation, as admittedly, but it sort of came down to like, well, what do I want to do with my life? Right? We have such limited time in the world, and I didn't enjoy surgery like as much as so many surgeons did. So my identity kind of was wrapped up in it, but it was sort of a matter of what I want the next 30 years to look like. And I had to sort of get rid of the, sort of like badass surgery part of my identity to feel like, I think I'd be better at listening and, exercising a lot of like love and compassion for patients through more emotional, psychological support.
Exactly. It's a different skill set that it needs for sure.
Yeah. Yeah. Some people have said along the way, both surgery and psychiatry are invasive just in different ways. And I don't know if that like means anything to people. But I think it's true. And I think there's there's an intensity to all types of medicine, but, psychiatry is both amazing and also really hard because I feel like of the body, we know so little still about the brain. It's really humbling, right, to be a psychiatrist and realize, how much we still need to learn.
Yeah. So it's funny you mentioned that about the invasive part. The way that I think about therapy, especially, is that it's like verbal surgery, where we have to be very careful about the words we speak, how we speak them, body language that we use, the tonality, how I structure an argument with someone, how I convince them to take medication. That's almost like a verbal surgery where I have to be a lot more cognizant. So I definitely agree with that assessment.
Yeah, completely. I was seeing a patient this week and, sort of really just making sure that I kept the patient's, sort of buy-in to treatment and make sure that I'm sort of aligning with their goals while also acknowledging like really risky symptoms like psychosis and instability. And how do we, sort of everything in balance to take care of them. I agree.
Yeah. Okay. So then you graduated psych residency. Did you do a fellowship?
I did not.
Okay. So then after residency, what did you do? How was your journey after that?
Yeah, so I graduated and I continued teaching at UCLA, so where I'm still very like loosely affiliated. I taught in the Women's Life Center there, so I was teaching other doctors, other psychiatrists, all about women's mental health. And then I took a bunch of, my goal was really to experience mental health in all the vehicles that are possible in our country. So I worked at the VA, I worked at the county hospital, I volunteered at a gang recidivism program called Homeboy Industries in Los Angeles. I opened a private practice to sort of cash pay me, seeing patients one-on-one. I worked at the UCLA Cancer Center. I worked at a residential treatment center. It sounds crazy, but as a psychiatrist, the beautiful thing is you can kind of work like a day here, and really see a diverse array of patients and diagnoses. And that's what I did initially. And then over time, I was able to kind of figure out what I really enjoyed and was good at, which was kind of seeing outpatients doing therapy and medication. So I kind of whittled those other experiences down till I just had a cash pay private practice. And then 5 years ago, while I loved that, I wanted to have a bigger impact than just me seeing patient one-on-one at a time. And that's when I started Remedy Psychiatry, which is like a telehealth only business in California. And we see children now, adolescents, adults with insurance and for medication management. So now I have a team of 5 psychiatric nurse practitioners, and we've seen thousands of patients, and we really work together. And so that's been really fun and interesting to just make a much bigger impact and to grow business and everything that's involved with learning, which for me has been really fun. A huge learning curve, but I really enjoy it. Even things like setting up health insurance and benefits and a 401k plan. And this way we work as a team, which is much more fun, and we get to help more patients too, like thousands, as opposed to just me helping one-on-one.
Exactly. Yeah. So you're talking about scale there, like how you scale something. And yeah, there's definitely a lot of topics I want to go into there. And so the first one I wanted to start with was some of your professional and clinical interests. So you mentioned talking about women's health. So tell us more about that. Like, how did that interest develop, and like, how do you practice in that area now?
Yeah, so it started because I'm a woman. So I liked, having that experience personally of going through a lot of these things, including childbirth and what a kind of emotional roller coaster that can be. And then when I was, I learned women's mental health through the UCLA Women's Life Center, which was an incredible group of female psychiatrists who've been doing this and sort of started women's health and psychiatry almost in our country. Dr. Vivian Burke was the head of the clinic, and she's just incredible. Kind of a worldwide expert at this point in women's health. And so the more I got into it, the more I realized women's health is really unique because while we're all men and women and people of all genders are subject to hormones driving mood changes, for women, it's so extreme, right? So it starts like at puberty when the rates of depression in women go much higher than men, and it's all driven by female hormones. And then of course, in the peripartum and postpartum depression, rates of depression, it's almost, I explain to my patients, when things are kind of the order of 1 in 5 or 6 women are going to get postpartum depression by the odds, it's almost normal, meaning it's not normal to feel that way, but there's nothing wrong with you because you're depressed. This is just what happens to women because of hormones. And it's almost as if someone's coming up behind you and injecting you with a huge vial of hormones. That's what kind of pregnancy is. It's just that your body's doing it to yourself. So we have no control. We can't blame ourselves. And so I think that was really interesting that, we have the inputs of life and environment to all genders, but with women, these hormonal changes are so significant and drive such significant mood changes that it was a really interesting part. And obviously it's half of our population, so it applies to so many. And then similarly, I have an area of specialty in psycho-oncology, or I worked at the UCLA Cancer Center for a couple of years. So I, in that capacity, I only saw cancer patients or their family members. And that was really interesting. Lots of learnings. I really would just love learning in general. That's like my hobby, I would say. But it was interesting in ways that I might not have even expected. So for example, things like, support groups. We think, oh, you've got a problem, join a support group. They're actually not for everyone. So some people love support groups, right? And they feel so validated and wonderful. But I had, a couple very young cancer patients who tried to get support through a support group and left feeling horrible when they realized the support group was all 90-year-old people. And here they were kind of a young person and had nothing in common, and it sort of left them feeling almost traumatized. So, just realizing the true spectrum of each individual and that everyone ultimately has to be treated like an individual because we are, and we can have such different responses to the same treatment intervention, even like a support group, but of course a medication too. So it was wonderful to see in people, towards the end of life. And I mean, that's a whole fascinating topic in and of itself, how people deal with, death. Some people are sad and grieving. Some people are totally in denial. And some people are raging, really, really angry right up until the end. So humans are just endlessly fascinating.
Yeah, no, absolutely. And then, with the women's mental health, something you mentioned that stood out to me was that a big part of your job, it sounds like, is just giving reassurance, where you're giving reassurance to your patients and to the women you see that, hey, it's okay, this is normal to experience. And that seems like a big component.
Yes. In fact, I was talking to a patient yesterday about this, and this patient was, really just expressing a lot of negative feelings to themselves. It was a new parent, and they were saying, I'm feeling like my baby isn't that great for these reasons, and I'm not that bonded immediately. And there was such shame because there's such cultural norms that we have, at least in America, which is when, someone has a baby, you say things like, congratulations, even though 50% of pregnancies are unplanned, by the way. Maybe the person never wanted a baby, right? But then you say, aren't you in love? And a lot of people are not bonded to their babies right away. So they're not yet in love, right? There's all these sort of pressuring things that we say, and we mean well, right? The base is we care about this person, but a lot of times the care is lost in the sort of superficial message. So anyway, this is a way of saying to this mom, part of what I was saying is look, lots of parents aren't bonded to their baby from day one. It's okay. This is such a foreign concept to you, especially with your first child. And sometimes dads don't feel bonded for weeks or months, right? And by the way, 10% of dads get postpartum depression. So even though they're not giving birth and having hormonal changes initially, there's a lot of chemical and emotional things that go on with parenting, and it's not perfect. And
Yeah.
it's bad for not feeling immediately bonded to their baby, right? It's sort of like a moving lump that doesn't even smile until the neurodevelopment is 6 weeks in and they can sort of reciprocate smiles. So I do a lot of normalizing, right? And I think even in the pandemic, like, at one point the rate of anxiety and depression in our country was about 49%. That's half of us were anxious or depressed. So when something is half of a population, it's kind of normal, right? We don't want to allow people to suffer, but they're not wrong or bad or even abnormal. They're just in it, so to speak.
Yeah, got you. And when you say that, a big part of your job is normalized, I didn't think about at the beginning of pregnancy, it may not even be a wanted thing. So they're struggling with identity, they're struggling with rationalizing, do they want to keep the baby, all that. What are the biggest issues that you see during the pregnancy time?
I would say, for sure. There's so much how to answer that most succinctly. I think the societal expectation is the leading driver for a lot of negative experiences in pregnancy. So it even starts, for example, many women are on antidepressants or medication to maintain mental health, and then they'll see their OB, which obviously they have to. And the OB is mostly concerned about the baby. So some of the first conversations will be like, oh, well, it probably would be best to get off your medications if you can. And OBs don't have a lot of time, right? So they're sort of saying this like because they have a job to get done too. But what really is needed is like a more detailed analysis. Well, what is this woman going to do or say or feel off her medication? What if she's suicidal and she ends her life? That's not worth it. So I think starting even just from getting pregnant and sort of reevaluating medications, those are kind of the biggest issues, where the best case is if a mom is well informed, like these are the medications I'm on, or this is my anxiety and depression, and it's safe to be on them or it's not. And I either want to stay on them or I want to try to go off, and I have support. So the medications are kind of a really big question. And then I think the other biggest issue around pregnancy or peripartum is just realizing that the hormones really can change, and some women feel the best they ever have in their life and some women feel the worst. And again, that's just all part of the spectrum, and it can be normal. They just need to kind of reach out and let someone know.
Yeah, I think you said something very interesting there. You said that OBs are worried about the baby. So they're not worried about the mom at all during pregnancy, like in your...
Well, yes. They're definitely worried about the mom. Obviously, we need a healthy mom to have the healthy baby. So I don't mean to, I definitely don't want to dump on OBs and say they're doing a bad job. I think it's more, right, our medical system, like appointments are very short, and, OBGYNs don't have an hour to spend with each mom at each follow-up appointment. None of us do as doctors, right? In our country, unfortunately, I wish we did. But to spend an hour checking in on the mom's depression and like, hey, what's your entire psychiatric history? Because when we talk about your medication, we need to be taking into account, your suicidality 20 years ago type of thing. So OBs obviously are caring for the baby and the mom for sure. And it's hard sometimes to get the whole backstory of a mom's psychiatric history to know whether to say to the mom, and some OBs do this actually, please stay on your Zoloft, right? We want you to stay stable. And so I give a lot of credit to OBs who kind of know the risks benefits. But it's just that there's a lot of details in there that can be lost. So unfortunately, it comes back to each woman to kind of really know themselves and get a team to support them, and also just get the information like, okay, I've got to stay on my Zoloft because I got really depressed when I was off it and it's not worth it. Or, hey, I've been on the Prozac and I go on and off and it's totally fine to go off during pregnancy.
Yeah. Interesting. Okay, that's good to know that. So could you walk us through for example, like an example case that you had, that you treated someone in pregnancy? I think it'd be very helpful to us just to walk through a case. because a lot of us don't really interact with patients who are in the pregnancy stages. You know, a lot of, I mean, me too, and like a lot of our provider audience, we don't. So hearing your perspective would be great.
Yeah, so I've seen so many women. I'm trying to think of sort of like, you know, to maybe make up a generalized case, not with any, you know, obviously individual patient details, but I have a lot of patients who are on, you know, an SSRI, like Zoloft or Prozac, for example, for, you know, 10 years of anxiety or depression, and like a little bit of a benzodiazepine. Like if they have a panic attack or go on a flight, they need, you know, an Ativan or a lorazepam. And so they'll often say like, okay, I want to get, you know, I just got married or not, and I want to get pregnant in the next year. Like, what do I do? And so generally we'll check in and say, okay, you're on Zoloft 100 right now, for example, how are you feeling? And if they say, okay, like I'm good, there's actually no symptoms now. And my next question is to them, you know, let's talk about Zoloft in pregnancy. And in general, we know that it doesn't cause any major birth defects, meaning birth defects happen to all women on the order of, depending on the study, 3 to 5%. So even if a woman's on no medication, birth defects happen because of genetic recombination or God or whatever you believe in. But that's how it is with medication, with women on no medications. Now, if you take the same, like 100 women on, and then you put them on SSRIs, the rate of birth defects is about the same, 3 to 5%. So we don't think that the SSRIs increase the risk of major birth defects. And then I talk about a little bit more of the details, like small nuances for babies born to SSRIs. But I sort of start to educate them on the risk benefit analysis, and then I turn it back over to them. What do you think you want to do? Because some women say, I know I need it. Like, I'd like to stay on it. Let's talk about that. And other women say, I have to get off. Like, I've had it in my, you know, head that I will not be on medication during pregnancy because of reasons A through Z. So if someone wants to go off, what I generally recommend is, okay, let's try to go down on your dose, taper down, and check in at certain points so we can see how you're doing. Ideally, if we can get you on a plan for 6 months and feel stable before getting pregnant, that would be great, because then you know, okay, I've been stable off medication for 6 months, and it gives you the psychological confidence that you're probably okay off of medication until you get pregnant.
That would be before the pregnancy. You'd recommend the patient get off.
If they want to. But again, that choice, it's sort of, obviously it's ultimately up to them. I'll also go through someone's history though. And if they have multiple suicide attempts, for example, you know, I will sort of say to them, the risk of going off medication is very high. So some of the data we know is that, you know, a woman who goes off medication for depression has like a 3-fold risk of postpartum depression compared to someone who stays on medication. So the data is really clear that if women have recurrent depression, the risk of having postpartum depression is higher if they go off their medicine. So we kind of talk about some of it, and it's really about a lot of education so that they can make an informed decision and have their partner weigh in too if they want to. And then I recommend whatever path they choose, we check in about every month, since all the hormones in pregnancy change so frequently that mood can change frequently.
Gotcha. Okay. So I know that a big question that I get is which meds are safe in pregnancy, which meds are not safe. Should I continue this? So do you have a list or a general, okay, these meds are safe in pregnancy, these ones are questionable, and these ones are not, should not take them in the psychiatric realm?
So I wish I had like a super succinct list. You know, in general, the SSRIs and the SNRIs, so they're, you know, Zoloft, Prozac, Lexapro, Celexa, they're generally, and, you know, Effexor, Venlafaxine, I mean, you can look them up, but SSRIs and SNRIs are generally thought to be safe and don't increase the risk of major birth defects. Then you have risks, you sort of have a like, so we'll call that a green light group, essentially. Then we'll have kind of like a yellow light group. And there are a lot of medications in this group, like some mood stabilizers, like lithium, for example, which are tied to some birth defects, but that we still use on a case-by-case basis because they can keep the mom really stable. And the most important thing about pregnancy is to have a healthy baby. We actually need to, number one, have a healthy mom. So in the postpartum and in pregnancy, I actually remind people over and over again, it doesn't matter a lot of the details. Like, number one is actually healthy mom so that the baby can be healthy. And then we talk about the baby.
Yeah.
So there's a lot of sort of yellow zone medications, we'll just call that, and no reference to genetic testing. And that's like a whole different story, right? Yeah. And then there's some red medications, although I would say in psychiatry, so for example, the benzodiazepines like Xanax and Klonopin and Valium, right? They can be associated with cleft palate as a birth defect. And so we generally don't use them in high dosages, but even those, sometimes they're the only relief that a mom can have. And what we always want to be looking at the risk of a medication exposure, but also the risk of illness, right? So if a mom is depressed or self-harming or drinking 3 bottles of wine because she's off medication, but she's really depressed, we want to know about those exposures, or doing a ton of drugs, right? We can't think about just medication exposure without thinking about disease exposure.
Yes, facts. Something I say a lot is that untreated cortisol in the mom causes more damage to the baby than basically treating the mom.
Yeah, I think it's true. We don't even know the extent of that. I would agree with you. But it's hard because we don't even know that. So sometimes I've seen moms who are like white knuckling like their anxiety, like, I can't be on medication. And it's like, we also have to think about how this anxiety and the cortisol and the under eating and the no sleep is affecting the baby. And our research doesn't fully tell us that, but we have to try to think about the severity of those anxiety symptoms, for example.
Where would antipsychotics fall in? Like, which category?
So more and more, a lot of research coming out of Harvard and the women's clinic there showing a lot of great safety data. So we're using, the antipsychotics more and more in pregnancy. So I've had patients on quetiapine and Abilify, and certainly lithium, that's not an antipsychotic, but throughout pregnancy. And we have more information on the older drugs just because they've been around longer, like quetiapine and Abilify. But more and more, we're showing that they're safe. And we want to look for kind of metabolic weight gain type side effects as well. But the data is really reassuring the more information we have on most medications during pregnancy.
Gotcha. And so what about mood stabilizers like Lithium and Depakote? My understanding was that those can cause issues, especially during the first trimester. So would a strategy be to take the mom off for the first trimester and then start them again on the second and third, or just continue them on?
Yeah, so great question. In general, and this also comes up because there's a black box warning, for example, on some of the SSRIs that say, like, in third trimester, they can cause certain side effects. So some people get in their heads like, okay, we should go off or on, or we should go on and then off at the end of pregnancy. Any off and on is going to induce mood instability or theoretical instability. So in general, in pregnancy, it's best to sort of get stable and stay on medication and be monitoring. There are some side effects. So for example, Ebstein's anomaly is a known heart condition that can be a side effect of lithium exposure. And lithium's the best mood stabilizing agent, right? The gold standard that we have in psychiatry. So generally, we educate moms on this small risk of this heart defect. But we also educate them on the risk of instability, right? With bipolar disorder, that includes psychosis, which can include self-harm, suicide, infanticide, right? Killing the baby. So the risks, again, of untreated illness are really high. And so for many moms, we keep them on lithium and we just do extra cardiac monitoring and that sort of thing. So it's really kind of a case-by-case basis. But because of that, we don't usually take someone off and then put them on or change medications, because we never know if someone's going to respond as well during pregnancy, because there's so many other hormones. It's like they're on a different medication, which is the hormones, and the sort of the terms and symptoms might be different. So generally, planning and kind of the goal of stability is ideal.
Got you. Okay, so if we can keep the mom stable, that should be a higher prioritization than potential DCing of lithium, worrying about birth defects. That's what you're saying.
Yeah. And again, it's, case by case because the mom needs to feel accepting of some of these, rare conditions that are risks. So it's really up to her. But in most cases, like in bipolar disorder with pregnancy, this stability is sort of everyone's number one goal.
Yeah, got you. And then what about Depakote? What are the risks associated with Depakote in pregnancy?
So, and I haven't had a patient on Depakote in like years. I think for Depakote, there's spinal birth defect risk for which we're monitoring folic acid as we do with some of the mood stabilizers. So making sure moms have appropriate folic acid supplementation is important. I haven't had a patient on Depakote in like years, like over 10 years, in part because I don't use a lot of Depakote, at least in women, in part because of this. And because of other things like weight gain, it's often not like a favorite, although it can be great with bipolar mania specifically. But monitoring for folic acid and, prenatal vitamins to make sure those risks are low are important too.
Got you. Okay. And then what about stimulants in pregnancy?
So another great question. So most of the historical data on stimulants were done on patients with like using meth recreationally for, with like co-occurring alcohol use. So it wasn't a lot of great data. More and more though, we think that stimulants or ADHD medications used at prescribed dosages without other substances like alcohol use disorder in the mix are thought to be safe during pregnancy. There's always a risk with stimulants of elevating blood pressure, which, we need to monitor for sure in moms anyway, because it can happen during pregnancy. But during pregnancy at prescribed dosages, we think they're relatively safe. In fact, the issue often becomes more after birth. If a mom is breastfeeding and they're on the stimulant, the baby needs to like be hungry and then wake up and then feed to stay on their growth trajectory. So in some cases, the mom's on a stimulant, they may also have the side effect of lower appetite, just like, adults do. And if they're not waking to feed, they can fall off their growth trajectory, which I've had happen with patients. As long as the pediatrician's in the loop and aware and we kind of know what's going on, sometimes moms will kind of elect to go down and off their stimulants if they can and make other, arrangements to address their ADHD symptoms in the meantime. But just to make sure that decreased appetite as a side effect of the stimulant is not causing the baby to, fall off the growth curve. So that's something to kind of keep in mind.
Interesting. Okay. But you wouldn't expect any kind of cardiac problems to the mom with the stimulant?
Aside from monitoring for like elevated heart rate and blood pressure, not like any major cardiac problems during pregnancy besides that on top of anything existing.
Okay, got you. And then what about a chronic benzo? For example, mom has significant anxiety, takes Klonopin once a day.
Yeah, so somewhere along the line, someone from Harvard said something, and this is not like quotable, but was like, oh, I don't really worry unless it's like many milligrams of Klonopin a day. I mean, the benzodiazepines, they do have this association with cleft palate, which is just essentially like mostly cosmetic malformation that can be now corrected really well with surgery, right? So that's sort of something to keep in the back of one's mind if someone's on Klonopin or any daily benzodiazepine. If someone is on it though, and they can kind of titrate off, so say they're using it for panic attacks, like, as you said, or, once a day, I'll usually say, like, is there another medication we can try before you get pregnant and see if we can get down to just using the Klonopin, like, as needed when you have a terrible panic attack or you have to go on a flight and you can't do it unless you have a benzodiazepine. So we'll kind of try to replace it, in other words. But I have had patients who nothing else works and they need to be on a benzodiazepine, and we just kind of alert the pediatrician so the baby can be monitored for any symptoms of withdrawal, which usually don't happen unless a mom is on a higher dose range of the benzodiazepines.
Got you. Okay, so that's good to know. So overall, basically, most meds that we at least use are they're safe to relatively safe, and we should be prioritizing the mom's mental health more than is currently done, because that will be the best thing for the baby.
Yeah, I think that's a great summary.
Okay, awesome. So now let's say the mom is approaching delivery, she's 8 to 9 months. What do we need to know as psychiatric providers about that time?
So one of the biggest things to know is that because the hormones start changing just a few weeks before birth to prepare the body to give birth, is that mood changes and postpartum depression and anxiety can even start. It's called postpartum, obviously, like post-delivery, but it can actually start in the final weeks of pregnancy, right? And it's also really tricky because some people will say, well, I'm feeling more anxious, and everyone says, well, it's just because the baby's coming, it's normal. But it's actually the time for those of us caring for moms where we should be even more attuned to, well, is it really just that you're getting nervous about having your first baby, or are there really kind of some more symptoms of anxiety and depression popping up? And so that's kind of even before delivery is the most important time. And then, for delivery, there are some risk factors for postpartum depression, like unplanned pregnancy and lack of community support that we can try to help parents with. So one thing is saying, if you have family or friends that you trust that can come into town to help you for a few weeks, let's do that. Let's create that village around you so you feel more supported. Another thing that I see a lot in postpartum depression is it's so consuming to become a parent. You go from having this like pie chart of who you are, right? Speaking of identity, like, oh, I'm Kirsten. I'm a doctor and I like to run marathons and I like to do art stuff. And then all of a sudden it's like parent, 100%. I'm just like a mom. All I do is mom all day. And then a couple weeks in, it's like women feel like they've completely lost their identity because they're just 100% mom. So I encourage them to just starting at day one, take 15 or 30 minutes yourself to touch who you are as an individual. Maybe that's like having a coffee or a walk by yourself. It's a win for everyone because you get to remind yourself, I'm Kirsten. I'm not just a mom. The partner, if you have one, or family member gets to bond with the baby. And you're also modeling from that very young age to your kid, hey, it's good and healthy to be alone at times. And you're going to be safe without mom. And mom enjoys herself so much she spends time alone. So it's like a win for everyone, for moms or parents to spend a little bit of time alone, starting from the beginning.
Okay, that's such a good point then. So one is the hormonal changes that are happening. Two, it's the big identity changes too. We're going from not being a parent to you are legitimately as a child here, and now it's all consumed.
Yeah, it can be.
Yeah, got you. Okay, so I've also heard a thing that moms who develop postpartum depression, for example, always screen for bipolar disorder because that's indicative of bipolar. Is that accurate?
So I would say, universally all humans should be screened for bipolar disorder, regardless of, and all things. I was actually seeing something on TikTok. Actually, one of the other psychiatrists on TikTok was saying, Black men don't get screened for eating disorders because there's assumptions, X, Y, and Z. It's like, in my book, it's sort of like this, it's almost like just not even a spectrum. It's like a big circle. We should all be screened for everything, right? And it could pop up, even bipolar disorder can pop up for women late in life after pregnancy. So for sure in the postpartum though, making sure checking again, right, for symptoms of depression, but then yes, bipolar mania and psychosis. And, one of the biggest things in postpartum depression that we see is a wired tired. So instead of just, moms are exhausted because they're up all night, but instead of being able to sleep, when they go to sleep, they feel wired and anxious and they can't. And that vicious cycle of insomnia is super, super dangerous. So for sure, rescreening, I guess, would be the answer for mania or, bipolar or psychosis in the postpartum is really important.
Yeah. Also, what I mean by that, going more in depth, is that, okay, let's say I have a mom who's having postpartum depression. Should I, because she's having some postpartum depression, should I use an SSRI? Or because with the timing, I think the chances are higher that it's a bipolar spectrum illness, and therefore I go with a mood stabilizer or an antipsychotic instead.
Gotcha. So I think making sure all the symptoms are very delineated, you would only want to go with an SSRI if at that point there's no suggestion that there is bipolar disorder. So I think, overwhelmingly, most people presenting with postpartum depression or anxiety and just those symptoms have just a depression and anxiety. And the SSRIs are, well, now with Zurzuvae, right, which is a hormonally based intervention, which is maybe a different topic, but treating those symptoms is usually best done with the SSRIs. But if there was any question of so you would kind of in general go with those. But if there was a question, then you would probably start an antipsychotic first if there was a possibility that it could be mania or bipolar disorder.
Got you. Okay. And then postpartum psychosis is a thing too. Why does that happen?
Why does it happen?
Yeah.
So, presumably all of these postpartum things are just caused by dramatic changes in hormones that dramatically impact women's brains. And we don't necessarily know why some women are more affected. And, some women get no postpartum depression and they feel fine. And then some women have postpartum psychosis. So it's triggered by hormones due to pregnancy and delivery, when the hormones really shift, right? In this fourth trimester is when the hormones kind of really shift right after delivery. And we don't necessarily know why, but women with bipolar disorder and, of course, any history of psychosis are at a much higher risk of postpartum psychosis, which is a medical emergency for both mom and the baby because of this increased risk of delusion, such as, I need to kill the baby to keep them safe, which is a semi-common sort of delusion in this period. Really, really.
Yeah. Have you ever seen that before? I need to kill the baby?
Well, I've thankfully never had it get that far where I was seeing a patient while that was actively happening, but I've definitely reviewed a lot of case reports, and obviously we see them in the news too. And that does happen. There sort of are some of these interesting patterns when it comes to postpartum depression and anxiety. In fact, one symptom I see a lot are intrusive images. So not necessarily a postpartum psychosis, but a postpartum anxiety. Women will have almost these flashes of intrusive thoughts about bad things happening to the baby, like baby being hurt, baby being killed. And they're intrusive. They don't want to think them, but for some reason, the brain responds that way.
Right. Got you. Okay. And then you were also mentioning the medication too, the Zuranolone. Is that what it's called for postpartum depression? So
Yeah.
I've heard a little bit about it. What makes this different than just an SSRI for postpartum depression? Do you know, are you familiar with it? What are the advantages of this med?
Yeah, so it's a relatively new medication. Originally came out a couple of years ago as an IV only, which of course didn't make it available to many people because most moms are home with their baby unless it's an emergency.
Right.
And then in the last 2 years came out as a pill, so it's much more readily available. And it's basically it's resetting the hormones and the hormones that affect GABA in the brain. So GABA is our neurotransmitter of relaxation, and it's triggered in many ways, including alcohol, benzodiazepines, but also through hormones. So this is sort of a synthetic, so man-made hormone that sort of acts like hormones in real humans to kind of reset the mom's hormones. And it's only 2 weeks of treatment. And the data kind of shows moms can feel better within about the first week. And I've seen it work many times. It doesn't work with everyone 100% of the time, just like any of our medications. But it kind of resets. And even after the 2 weeks, if it's working, the symptoms are kind of kept at bay. And it's nice because the SSRIs are treating, obviously, the postpartum depression at serotonin, but not really at the hormonal level. And this is actually treating more of the root cause. It's still a bit of a pain because like you have to do all this insurance applications and it takes like moms are suffering. I just did it last week. It takes like a week to get through insurance and stuff like that, requires some patience, but it's really exciting to have something that's addressing more of the root cause of the depression.
Got you. Okay, so walk us through the administration and the dosage of it.
So the main dosage, it's like a 25 milligram capsule, and most people are going to do 50 milligrams, so 2 capsules a day for 2 weeks. Sometimes people will have, it can be really sedating, which is often actually nice because moms have that wired tired, and sometimes they need sleep medication anyways. But if they take this, recently a mom kind of said like, wow, I felt like totally knocked out.
Yeah.
And if it's too much, they can cut the dose and be on kind of half the dose if necessary. But the goal is kind of the 50 milligrams for 2 weeks, and then they're done. Unfortunately, insurance is only covering it once. We had a theoretical question of a mom who was stopping breastfeeding like about a year or two after having her child. And obviously that triggers a hormonal change. So we wondered, and this parent was actually a pharmacist and very educated. And the question was, even though there's no data, maybe this could help the second sort of episode of postpartum depression with the hormonal change due to breastfeeding, but insurance refused to cover it, which is frustrating. So generally we use it once for each pregnancy, and that's what it's technically being covered. And the cost is somewhere on the order of $15,000 without insurance. So it's, unfortunately limited to people with insurance coverage.
Right, got it. Okay, so basically, let's say the patient has postpartum depression. You want to start something, you look at, it's called Zuranolone. Is that the?
Yeah, Zurzuvae is the brand name. Zurzuvae. And yeah, you kind of work with a specialty pharmacy to get it prescribed, and it gets delivered. There's a lot of pharmacist-patient calls that have to happen, but it can be taken at home by pill, which is great.
Got it. And then the dosing, you said it comes in a 25 milligram capsule, so the dosing is 50 milligrams BID.
No, it's 2 capsules, and this is, I'm pretty sure. So if I'm wrong, sorry, but 2 capsules, and generally we take it at night because it's sedating. So it can be taken all at night and help with sleep. Theoretically, someone could take it twice a day, but because it's sedating, we put it at night.
Okay, so it's just 50 milligrams once a day at nighttime. That's the standard dosage. Is there a titration? Is there a max dose, or it's just straight?
That's the dose. Generic is Zuranolone, Zurzuvae. I saw someone is asking about that. And again, the dose is kind of intended to be 50 milligrams if it can be tolerated. If someone's like I had a colleague who said their patient was just like completely sedated, like slept for 20 hours, then they would like cut the dose to a smaller size so that they could still be like awake during the day. You don't want to put someone at risk, obviously.
Got you. Okay. And just to reiterate again, what is its mechanism of action?
So it's a synthetic hormone, so like, man-made, chemical, lab-made hormone that's working on the brain to sort of change GABA levels in women who've had hormonal shifts causing depression.
Got it.
And that would be my hormone pathway to give you more details than that, but that's generally how I explain it to patients.
Gotcha. And then you can stack it with an SSRI. There's no contraindications there.
Yeah. And some people may already be on an SSRI and it's just not working, or I've had some patients want to start an SSRI at the same time, or try that first, see how it goes, since generally you can it's one of the few medications you can feel better often within a week. And then they can wait and see if they still want to go on an SSRI.
Gotcha. Got it. Okay. So yeah, I'm glad we delved into this peripartum, postpartum. So let's talk about menopause now, because I know that's another issue that a lot of women run into. So what should we as providers know about, I guess, premenopausal, menopausal, postmenopausal changes in women?
Yeah, I think the biggest thing to know is that as of, I think it was last year now, there was sort of a study that came out that said for any women over the age of 35, we should all be thinking about perimenopause. And the reason that's important is because a lot of women start to have symptoms in their late 30s, but certainly 40s, 50s, that are odd, and they feel a little crazy, and they might go to their primary care doctor or mention to a friend or go to their OBGYN. And because it's sort of like little symptoms here and there and doesn't add up to a big picture, women often feel invalidated by the world, even themselves. And the reality is a lot of them are just percolating symptoms of perimenopause. So our hormones are kind of starting to change even in our late 30s. And perimenopause can happen for years and years before menopause, right? So menopause is defined as a year with no periods. But some women have 20 years of symptoms before that actually happens. And that's all perimenopause. And it's very random things, right? So frozen shoulder is a sign of perimenopause, regardless of whether someone's like exercising or not. But then, of course, hot flashes at night. So it's all the things people think about or know when they think menopause, like, oh, sweating. But it's a lot of things like brain fog. Lots of women are like 40 and all of a sudden, do I have ADHD? And it's like, no, but you do have perimenopause, and it's severe. It can cause anxiety, depression, right? First episode of bipolar disorder or schizophrenia in rare cases, but also like brain fog, ADHD-like symptoms, and a whole bunch of other physical symptoms. So I think the biggest thing is to sort of have women realize, look up all the symptoms and say like, oh, okay, this is what's going on. I'm not crazy. I'm not making things up. And then align them with mental health care or general care where they feel like they're being heard and they can hear their options, which often include hormonal therapy or HRT, hormone replacement therapy. And just like at least getting the education is kind of the first piece. And we do use SSRIs for those as well, but there's some data that, again, because the cause is actually hormonal, that in some women, the SSRIs don't work as well as they might have in their 20s when it wasn't like a hormonally induced anxiety or depression.
Yeah, got you. Okay. So psychiatrically, psychologically, what are the symptoms that someone might experience as they're transitioning, like in the perimenopause, menopausal area?
So it's like so wide and vast, but I see a lot of anxiety, like first time in life, kind of being like, what is going on? I'm so like anxious, or even OCD, but for sure depression. And some women I've had patients try HRT and actually have really bad side effects. So unfortunately, it's not like a panacea. There was a really big New York Times article that was like, my read of it was just like, everyone should go on hormones. And I wanted to say, like, not everyone necessarily. Some people have really bad reactions, right, to birth control or to HRT, right? So everyone has to be treated like an individual. But, the anxiety, the OCD, the rumination, and the number one symptom I see, irritability. So some people feel like, oh, maybe this is just like wisdom. And maybe it is wisdom, but it also is the number one most common symptom I see in perimenopause too.
Okay, so it's the irritability, right? And then when you talk about HRT, that's conducted by an endocrinologist, correct? Like that or is it an OB-GYN? Would a psychiatrist ever do HRT?
So for the most part, it's OBGYNs because they're going to be giving hormones, but also monitoring things like uterine lining with, ultrasounds and things that hormonal treatment might cause side effects of that need to be monitoring. So some psychiatrists will do hormones. I don't generally do that because I'm not doing vaginal ultrasounds to check uterine lining. So often it's OBGYNs that are the sort of like primary right now place to do HRT, treatment. Endocrinologists, I think they can also weigh in, but most people see their OBGYN once a year, and that's the easiest place or their primary care to sort of start the conversation.
Got it. Okay. And so that's the main thing with perimenopause, postmenopausal. Anything else that you think we should know, the general psychiatric provider should know about those two areas of life?
Just that I think the sort of the drip of information, the education should be, let's talk about, SSRIs and the anxiety and depression, but let's also keep on our mind that hormones might be the root cause here. It doesn't mean you have to do hormones, but that we're just keeping that on our radar in case things change and you might want to explore hormones in the future. because it's just, yeah, if the SSRIs aren't working as well, it's kind of important to kind of keep revisiting options. I think that's always a good choice. So talking to patients, I always talk to patients about like all your options for feeling better, right? Lifestyle, community, sleep, exercise, talk therapy, psychiatric medications, but also TMS and, other types of treatments like ketamine, things like that.
Yeah. Got it. Okay. So really that is that awareness that it's hormonal based, and we have to keep that in the mind. Like that's the underlying mechanism.
Yeah. Yeah.
Yeah. Got you. And then I know we also skipped over it too. I meant to ask about it. So PMS and PMDD. So talk to us about those then. Like, why does that happen? I mean, how prevalent is it?
Yeah. So PMS is, premenstrual syndrome. It's sort of the like, I guess we call it like just irritability, or what people like to say, like she's PMSing. That means she's like moody and irritable. PMDD, or premenstrual dysphoric disorder, is a true disorder, meaning the symptoms are so severe, they're impairing. So some of my patients with PMDD, they have to take days off of work because they can't function on those days, or they, cancel plans because their symptoms and mental health symptoms are so severe. And PMDD is sort of, in other words, it's hormonally driven. So every period or every month, they have symptoms that are so severe they're impairing. And they can be different, but generally it's such a mood decline or an increase in anxiety that they can't function normally. And it's really impairing to life. And there's a lot of things we can do to kind of treat them, but including SSRIs, which are kind of the mainstay of treatment.
Right. Because let me get your thoughts on this, because I know one of the days of treatment is an SSRI, but you can also do like pulse dosing, where you do it for 2 weeks in the luteal phase, and then you stop it for the phase of the period, and you restart it again. Do you usually like that approach? Do you like more of the standard SSRI dosing throughout the thing approach?
Yeah, I mean, it depends on the individual. So for some people, they may actually already be on an SSRI for like baseline generalized anxiety disorder. And so what we'll do is we'll actually pulse up on their PMDD days. So for like 7 days, they might go up by 10 milligrams on their Prozac, for example. So those, we even do pulse style when someone's on a medication. If someone's on no medication and they feel like, man, I really don't want to be on medication, but these days are terrible, we often will pulse and just give them medication on those days. And then for some people, it's like they come in, they're not on a medication, but they sort of realize, well, like every day's a little bit hard. So let me just try the same dose. Also, if their period's irregular, they can't necessarily pulse it exactly. So we'll just put them on the same dose every day and see if that helps.
Got you. Okay. And so basically you're saying that if they, like, let's say they've already been on the SSRI, then you might pulse it up a little bit. If the periods are irregular, then you might just keep them on the same dose throughout. Do you like the pulsing approach, or do you like the more just consistent?
The pulsing approach really works for many women, and that's how it's shown to be true in the research as well. So it's really case by case. If someone's regular and they know their period and they use alerts, I think that is great because it lowers the sort of side effect burden if they have any side effects, like sexual side effects, for example, from the SSRIs. And it's giving them kind of the very minimal amount of medication they need. But for a lot of women, it's like, oh, my period's irregular, or I forget, and I can't keep track. It's so much work. It's a lot of work to be a woman. So for some women, it's easier just to say, like, let's just go up on my dose every single day. And, and oftentimes the PMDD symptoms will be kind of like muted enough where then they're just getting through the day. So I know that's a long way of saying it's sort of case by case, but it really depends.
Got you. Okay. And so I know we talked a lot about like the medical side of things. I was also curious in your thoughts on the romantic/dating side of things. So have you found that women struggle with any of those issues related to hormones, related to other psychiatric issues, any complaints that you've seen in your office, relationship problems? Like, just curious in your thoughts.
Like relationship problems as it relates to female hormonal changes?
Like hormonal changes, for example, during PMS or PMDD, or let's say during pregnancy, where there might be hormonal problems causing relationship issues?
So for sure, I think, and I hesitate to even say this because I think women are so often like written off in general because of, hormones or like choose PMSing, that I don't want it sort of women to feel like invalidated. But I think knowing that, a lot of the hormones can drive irritability. And I've certainly heard right in my office, like I was so angry at my partner and I realized I like didn't even realize why I was angry. It was more than I should have been angry kind of thing. And I think just exercising compassion, like nobody wants to be screaming at their partner unnecessarily. And if we could control that, we would. But again, hormones are like drugs being injected into us without our control, so we can't. So long way of saying though, irritability as a result of hormonal changes is really normal and common. And I see that in both PMDD or like the premenstrual periods, a couple of days before women get their period, the irritability is often higher, and tearfulness, like easy to tear up, is a really common symptom too. So those are kind of the things I see most commonly due to hormonal shifts. Like I'm crying and I don't even know why, or I'm so irritable and it's totally unreasonable. And that can make it hard, obviously, to be in a relationship with anyone or to date.
Got you. So it is something that you see commonly then. And like, I think one thing is that when you give just having awareness about it, I feel like would make a huge difference. If a woman understands that, okay, like this is my period, or this is a hormonal thing that's happening, it could help them have more compassion for themselves and less, I guess, judgment or less being blindsided because like it's just they're aware that this is like contributing to it.
Yeah, I mean, if there could be like one thing I could give to all women, it would be like simply compassion for oneself. As far as emotional changes are so often hormonally driven, that we just need to sort of give ourselves a break and say, we're not in control of this. Let's just be kind, realize what's going on, and then try to get support.
Yeah, got you. Okay. Yeah, I know we definitely covered a whole host of topics of PMS, PMDD, peripartum, postpartum, perimenopause, postmenopause. Is there any other areas that you feel like are neglected, not talked about enough, you feel like we should cover?
I mean, I would love to. Unfortunately, I have to go soon, but I think, I could just talk for hours about all of this. Yeah, nothing that comes to mind right now.
Yeah. Awesome. No, I really wanted to cover this because like this isn't something that I barely got any education on. So I'm sure other providers are the same way too. So, thank you for sharing all this with us.
My pleasure. Thanks for having me. And I look forward to hearing. And if anybody has any questions too, I'm happy to chat again with you or, answer any questions. So this has been really fun.
Yeah. So maybe, if you have to go, you feel free, right? Otherwise, usually people will leave questions in the chat. So I could go through a couple of those with you too, if you would like. It's up to you.
Yes, I have to go probably in a couple minutes, and I apologize. I didn't realize we get a chance to speak this long. Otherwise, I would have pushed some other things away. But yeah, if you do want to pick out, if you have,
I'll read out some for you.
Yeah.
So, Spring Marie says, can ADHD be misdiagnosed with anxiety in women?
Yes, totally. So when I'm, describing with patients, there's so much overlap in symptoms. It's always like a Venn diagram. Like if you have ADHD symptoms here, you have anxiety symptoms here, right? And one symptom of anxiety is impaired concentration because your mind's worrying about so much here. Of course, you can't tend to everything you're doing during your day. So very much they can co-occur as well, but they also can be misdiagnosed as one or the other.
Separate, right? Yeah. So Marilyn says up here that with my menopause, I've ended up being diagnosed BPD, autism, and ADHD. I used to want to end it with my period.
Wow.
Any thoughts, or is that a common thing? Like, do people get other diagnoses with menopause? Is it just a manifestation of the root diagnosis?
Yeah. So I think, okay, autism and ADHD. Yeah, I think, again, sort of thinking about a Venn diagram of symptoms, for sure, menopause and perimenopause causes like severe brain fog and ADHD-like symptoms. And so that's like ADHD. And right, mood changes also happen with perimenopause and menopause, and that can look like bipolar disorder. The important thing is having a really thorough history and evaluation with a psychiatric provider who asks you, has your whole life been like this? Or with perimenopause or menopause, we'll hear like, no, actually it was fine. It's just the last 5 years. And that's an indication that it's hormonally driven, right? If it's not, ADHD, for example, has to technically present before the age of 12. Doesn't mean someone had to be diagnosed before 12, but the symptoms had to be there before 12 to be the neurodivergent ADHD brain. So it's important to have someone taking like a thorough history with those details.
Yeah, essentially establishing a timeline. That's what you're saying.
Totally.
Aruna asks, female age 52 still have periods but anxiety and palpitations. What should I do? Heart tests are okay.
Yeah, so I think, getting a good exam first, you could start with primary care if you haven't, but certainly making sure your heart is okay and maybe seeing a cardiologist if the primary care refers. And if the heart is fine, right, then those palpitations could be something else, including anxiety. So, again, kind of making sure the body and the heart is okay, and then also working up kind of from a mental health perspective. Again, when did the symptoms start? Have they always been there? Has anything else caused them, type of thing?
Yeah, gotcha. Okay, that's helpful to know. And then TJ asks, she had a hysterectomy last January, still have ovaries, mental health slow decline since. So maybe just like about hysterectomies, like how does that impact psychiatric health?
Yeah, so technically hysterectomy is just removing the uterus, right? And if the ovaries removed, would be ovarectomy, which is impacting the hormones more. And it's hard. So at that age range, right, sometimes we misattribute things. So even though the uterus isn't like a hormone releasing main organ, like our brain or ovaries, taking that out can certainly affect the body, but also at the same time, there may be perimenopausal or menopausal brain changes that happen. So it's hard to know sometimes, or maybe it's both causes, right? Maybe it has to do with hysterectomy. Maybe it could be about surgical changes. Maybe it could be the identity as a woman from a psychological perspective, but also could be hormonal changes from perimenopause or menopause too. So again, going through a more detailed history, when did they start? What are all the causes that could be there to try to narrow it down would make sense.
Yeah, really establishing that timeline.
Yeah, timelines are very important, very important.
Yeah, but no, thank you for your time, Dr. Kirsten. I would have loved to delve into private practice and other things, but maybe we could save that for a future one.
Yes, I'd love to do that. I'm so sorry to cut things short. I have to go pick up my kids actually. So,
Of course.
but yeah, I'd love to talk again. This is super fun for me. So thanks for having me.
Absolutely. Yeah. So thanks for being on, and let's chat soon.
All right, let's talk again. All right, bye-bye.
Bye.